Hello and welcome. Today we're going to be talking about the assessment of the lungs and thorax. My name is Dr. Bridget Miranda, and we'll be walking through the anatomy and physiology first, and then talking about the subjective and objective assessment. Starting with the anterior thoracic cage, you note here important landmarks that will help you guide your assessment and help you to figure out where you're going to percuss and as well as palpate and auscultate after you inspect. The first landmark is the substernal notch, which is a U-shaped depression between the two clavicles, and below that, a few centimeters down, you have the manubriosternal angle. We call this the angle of Louis, and this connects or correlates with the second rib. When you're counting intercostal spaces specifically, you always use the number of the rib above. So for instance, here you see the second costal or rib. The second intercostal space will be between 2 and 3. The third intercostal space will be between 3 and 4, and so on and so forth. Another important concept to see here is that we have 12 pairs of ribs. Here you can actually only appreciate 11. 11 and 12 are floating, so they're better appreciated from the posterior thoracic cage. Now you can see that it's 7 connecting to the body of sternum and the body of the sternum, and then after that it's cartilage connecting back to 7, and maybe you can argue that rib 8 is also connecting to the body of the sternum. What's important at this angle here is that where this connection is, where the xiphoid process creates this landmark where you will be able to see this costal angle. This angle, and we'll talk about it a little bit more in lecture, we want it to be at a 90-degree angle. And I want you to start thinking about why. What does it mean if the angle is larger or if it's smaller? What is this telling you about your patient's thoracic cage? Now looking to the posterior thoracic area, I want everyone to put their chin to your chest and feel the bony prominence that you can appreciate from your posterior neck. That's C7. This is the vertebra prominence, and right below that you'll feel T1. So using that, T1 correlates with the first costal on the posterior side. And from there, if you're going mid-scapulary line, you can start to count the ribs and the intercostal spaces. If you get a little bit closer to the spinal processes, you can count the ones that are between the scapula as well. And so just looking at this schematic, you can already assume that counting ribs and intercostal spaces in the back, it's pretty hard because you have muscle and soft tissue surrounding your ribs and your spinal column. I would even say that it's hard in the front too because on some patients, because of breast tissue or habitus, it makes it hard to find. So this is a process of learning that you may not grasp the first time you try to palpate or percuss your patient. Note that the spinous process aligns with that same number rib, and so that's why it's really important. If you can find your C7 and your T1, then that's where you are going to get that jump off point to continue counting. And as I alluded in the previous slide, 11 and 12 are floating, so they don't connect back to the body of the sternum or the cartilage that connects to the body of the sternum. They kind of float, and you only can see or feel 12 if you're standing posterior of the patient's posterior, Next, we're going to look at what do the lung fields look like underneath your patient, underneath that thoracic cage. And what's important to see here is noting the difference between the right and the left lung fields. And you can see that we have an extra or a third lobe on the right side that we don't have on the left side. Also note that where the left oblique fissure lies, it's different than the right oblique fissure because of that right middle lobe that you can appreciate fifth mid-axillary line to the fourth and the sixth rib if you are standing anterior to the patient. Now, you're looking at the lung borders just overall. You can also note that anteriorly, there's lung fields that rise above the clavicle, about 3 to 4 centimeters above this third of the clavicles. You can actually appreciate breath sounds. At the base, and this now is a true base, it's not like the heart where the apex was below and the base was on top. Here, because of the shape of the lungs, your apex is on top and the base of the lungs or on the bottom. And you can see that the base rests on that diaphragmatic line, and it's about that sixth rib in the mid-clavicular. Okay, so if you're counting mid-clavicular, it's about 6. And laterally, your lung tissue will extend from the apex to the axillary area down to that 7th or 8th rib. So if you're counting more axillary or palpating more axillary, you will find that 7th or 8th rib, and then you note that the lung tissue there actually extends into those areas. Posteriorly, C7 will provide a landmark that marks the apex of the lung tissue, both right and both left. Important to note here that at T3, this is where the left lower lung actually begins if you are mid-spine. And as you move to that mid-scapulary area, you could see that it's actually about T5 where you're going to appreciate the rest of the lower lung bases. But note that posteriorly, the majority of the lung fields that you're hearing when you use your stethoscope or percussing is going to be lower lungs in these areas. The lungs are paired. They're not precisely symmetric here, although it does appear that way in the schematic. The right lung is actually shorter. You think about why that might be. Now, if you think about the anatomy of your body, what is next to your lung fields on that side, you actually have your liver. And so that's what pushes up and creates that shorter right lung field. The left lung field is more narrow because your heart is bulging to the left a little bit. And again, the right lung has 3 lobes, so that when you are listening posterior to your patient and you get a little bit more axillary, you might appreciate that right middle lobe as opposed to the left side where it would still be considered that left lower lobe that you are assessing. Here's a better picture of the axillary line showing that right middle lobe. You can see there. And then here is that line on the left. Anterior reference points that we use to help us describe what we're hearing or where we're hearing what we're hearing and how to document that. Mid-sternal, anterior axillary, mid-clavicular line, which we know from our cardiac assessment. And then posteriorly, we have the vertebral line and the scapular line. So these are ways that you can help to your documentation, but also help communicate to another provider what you might be listening to or what your findings are that may be concerning. And you can see the lateral lines of the left side of the body as well. So we have the posterior axillary, anterior, and mid-axillary. So just shortly about the physiology of your lungs and thorax. We're just going to talk very basic. We're not going to get too much into the pathophysiology, but just think about the major functions of the respiratory system. And the first 3 are the most important here. Supplying oxygen, removing that CO2 when you are breathing and releasing that CO2 as a waste product, and then maintaining that acid-base balance, which is important to continue the homeostasis within the body. And this is achieved by supplying oxygen to the blood, but then as you're breathing it away, you're eliminating any excess carbon dioxide that is unneeded. And so this allows your respirations to help maintain that pH or acid balance of blood in your body. Least important here on this slide is the function of heat exchange. It helps to maintain heat exchange. It's a little bit less important in humans than it is in other mammals. Moving now on to age considerations. We're going to take a look at the different aspects of infants and children versus pregnancy and versus an aging adult that we need to consider when we are assessing for the lungs and thoracic cage area. Now, during the first 5 weeks of fetal life, you actually will have primitive lung buds emerging as part of the development. But it's not until you are at 30 weeks gestation that your body makes a substance called surfactant. And this surfactant helps to pop up the alveoli so that actual oxygen exchange can start working, your lung tissue can fill up, and that your pulmonary system altogether is operating at full function. The reason why we don't need surfactant prior to this is because the respiratory system alone isn't even functioning at birth, right? The birth demands its instant performance, meaning that once we cut the umbilical cord and the baby is detached from the mother, it kicks that respiratory system into gear. Now, if we talk about a premature infant that's born before 32 weeks, and even sometimes even at 32 weeks or older, they may not have enough surfactant to allow for this independent breathing, and these are the infants that are going to need oxygen support. We also want to consider with infants and children the impact of environmental tobacco smoke or secondhand smoke exposure that leads to an increased risk of SIDS or sudden infant death syndrome. It can also increase the risk for behavioral and cognitive delays, and there are studies that connect environmental tobacco smoke at a young age that exposure increases your rate of adolescent smoking. So all very important things to note and consider. With a pregnant woman, we knew all the changes that estrogen had on the body in terms of cardiac, but also estrogen helps relax the chest cage ligaments. So it's already more difficult to breathe because you have this growing baby inside, and it starts to push on that diaphragm and and start pushing that diaphragm up towards the thoracic cage. And sometimes it can even elevate that diaphragm up to 4 centimeters during pregnancy. So you can imagine how difficult it is to breathe. Well, this extra estrogen that you are getting will help to relax that chest cage so it could decrease the compression and it helps to breathe. Although, depending on what stage of your pregnancy, especially towards the end, it makes it even more difficult because of just the size of the growing baby. Now, the diaphragm is elevated, it can be elevated up to 4 centimeters, but this doesn't mean that it's fixed, right? It's going to move up and down with your breathing, and it's going to increase that tidal volume as well. Now, the growing fetus, something else to consider, is going to need more oxygen, and because we're growing a baby, it's going to increase the oxygen demand of the mother's body as well. With aging adults, we have to consider that there is going to be an increase in small airway closure, and this is because the costal cartilage over time, as we get old, it becomes more calcified, and when things get calcified, it makes it less mobile, and because of this limited mobility, we have less oxygen exchange, less ventilation occurring. The aging lung is more rigid. The structure itself, it's just harder to inflate as well. When we get older, the number of alveoli start to decrease. And we need alveoli because alveoli provides that surface area for us to exchange gas appropriately. So the CO2 and the oxygenation. And now when we get old, we don't have as much surface area to do that effectively. Our lung bases also become less ventilated as a result of the result of the closing airway. And we might even see some histological changes at the cell level especially putting our older patients at risk for post-op complications that have to do with their respiratory system. Another area of concern when you're thinking about, initially asking your patient some health history questions and getting an initial assessment is, understanding that the incidence in TB has declined here in the US, but we still have TB cases. And this is especially true if you have a person that is foreign born and has immigrated to the United States. You might see more incidence of positive PPD tests, and this may be largely because they have been given a vaccine for tuberculosis, and we call this the BCG vaccine. So there are some groups of people that will test positive, but it doesn't mean that they're positive for TB. They've just had this exposure because of the vaccine itself. And if you do have a positive PPD, the next thing to ask is, were you given the vaccine? If they say yes, okay. If they say no, all right, so that's going to vary your thinking or, branch your thinking off in two directions. But regardless, you have to say, well, I need to confirm this. So you can follow up with a chest x-ray, and then you can also ask for a quantiferon test, which is a blood test and the gold standard for TB. Something else to consider is just the culture and genetics. If we're thinking about asthma and the relationship that asthma has on the prevalence of children. Here in the United States, the prevalence is actually 8.5% overall. And then just in children 0 to 17 years old, it's almost about 10%. And it is increased with certain populations, but I also want just to draw your attention and think about location and how the location of where you live and the exposure to environmental toxins will increase your rate of asthma as well. So if this is a point of interest for you, do a little bit of research regarding how different areas of the United States or even in your community have an increased incidence of asthma. Now we're going to move on to the physical exam itself. We're going to start with subjective and then move to the objective history. So first, when we're talking about the subjective, we need to start asking our questions that are focused to this respiratory history, going back to lungs and thorax. This isn't doing the whole health history, just focusing on the patient's breathing and thinking about their history in terms of smoking, if they've had any past history of respiratory disorders, and think about what those might be. You might ask if they're having shortness of breath right now, and if they've had a history of shortness of breath. I want to know about lung diseases such as bronchitis. Maybe they have COPD or emphysema. They've had a history of asthma, maybe as a child, but also maybe they're struggling with that as an adult as well. Have they ever been diagnosed or treated for pneumonia? I also want to know just about their history of colds. How many colds do you usually have a year? Are they pretty severe? Do you need to be hospitalized, or have you ever been hospitalized for a respiratory disorder? Do you have a history of allergies? Do you have a history of TB or asthma? Now, to be timely, we also have to ask now, do you have a history of influenza and COVID as well? If you're talking about smoking history, I'm going to go back to that for just a second. You don't want just a yes or no answer. Try not to make this just a closed-ended question, but you really want to ask, when did you start? How many packs per day, so that you can get that pack year history down. I would also consider, is there somebody else that smokes in the house? Have you considered trying smoking cessation, or are you ready to stop smoking? Those are some other follow-up questions for your patient history. Also ask about their own environmental factors, and this could be connected to their occupational hazards. What do you do for work? Where do you live? What type of ventilation do you have in your workspace? And then if they're monitoring their exposure, what are they doing to take care of those things that they can't really control, Sometimes you can't control that you live in a certain space or that you work in a certain area, but are they using the proper PPE if we're talking about nursing or healthcare? Are they using the proper mechanical tools and equipment to help them? If you're thinking about maybe if they're a construction worker, are they using masks appropriately on the job site to help them not inhale the small particles? If they're a firefighter, are they using their equipment appropriately as well? In terms of self-care behaviors, I'm thinking about things like, when was your last TB test? If it was positive, have you had a chest x-ray? And, if you've had a chest x-ray, has there been a concern for pneumonia? I might even think about, again, going back to smoking, this would also fall under self-care behaviors. What things have you done? What type of interventions have you tried to stop smoking? Moving now on to the review of systems. And so the review of system here is just about their respiratory system. But you can see, and it also supports our cardiac lecture previous, is that the respiratory system is also connected to the cardiac system. When I'm asking for cough, I may be thinking, yes, cough in terms of, some type of environmental trigger, some type of respiratory disease, but maybe their cough really stems from their antihypertensive medications. Sometimes that's a side effect. Maybe they have congestive heart failure and they have extra fluid and that's causing the cough. Regardless, you're going to old cart the symptoms that they tell you. But these are one of the things, cough being one of the things that you really want to get a good handle on and really ask in terms of, what are you doing when you're coughing? How long does it last? What type of activities or positions increase or decrease the coughing? Is congestion a part of it? Do you have sputum? With sputum, what color is it? Is there an odor? How long has that last? When did it stop? When did it, start? And what helps that too. I also want to understand their shortness of breath. Is it with activity versus are they sitting down? And you want to start asking them about these symptoms in terms of how long have you had them and was it like that before, right? Was it like that last week? Was it like that 3 months ago? Trying to figure out the chronicity or how chronic the symptoms are that they are presenting with. I tend to try to rule out, even if they say they don't have a history of allergies, I want to rule out any type of environmental factors that might be increasing their symptoms at the time. And then lastly, what's not here that should be here is medications, right? What type of medications are you taking? Do you require oxygen? Do you require inhalers or other types of anti cough medicines or I'm drawing a blank right now on what they're called, but medications to help you not to cough as much. And what have you been using as treatment? If they have COPD, they might, they might tell you they have oxygen and maybe they're not using it, or they have been advised to stop smoking, but they've continued smoking. So you want to get all the information as much as possible. Additional questions that you might ask for infants and children is, if they've had colds, how frequent are these colds and what's the severity of the cold? I might even ask, are they exposed to other children in like a daycare setting, which hasn't maybe increased their signs and symptoms of respiratory illness? I might ask if they have a history of allergies. This is important because a lot of patients that have asthma also have other types of allergies as well that increase their risk for respiratory distress. I will ask them about congestion, sneezing, coughing, all the other symptoms that we associate with colds or maybe even a flu. I would ask now about COVID as well. I'm also wondering about their safety measures at home, talking about childproofing their home, because with this population, they tend to put things in their mouth and in other orifices of their body, but especially in their mouth. I'm thinking in terms of aspiration and choking. so any type of swallowing hazards that would compromise their respiratory system, and of course, secondhand smoke or environmental smoke, especially that enclosed environment like in a car or inside the home. For aging adults, I ask specifically for shortness of breath in terms of their activities of daily living. I want to know if they've had any change in weight. This is connected not only to CHF, which we've talked previously, but also to tuberculosis. And if you remember getting your own TB screening, one of the questions is sudden weight loss. So this is something that I want to back up with an answer, right? Any weight change. And also, with certain types of cancers, you can lose a lot of weight very rapidly. So not only do I want to know if they've had a weight change, but how rapid has this weight change occurred? And usually the question that you'll hear providers say is sudden, unexplained weight change, right? Not like you've been trying to diet and lose weight and you've lost weight, but unexplained weight change. I also want to know about energy level, if the same activities are tiring you out that you were able to do previously and now you're left with fatigue. Do you have any pain with breathing? And have you ever had a fall, right? And has anything changed since maybe your last doctor's visit? It's a good idea to understand, if they do have a chronic history of respiratory disease, when was the last time they saw their pulmonologist, and are they using their medications effectively? Now we move to the objective data. And so some of the assessment you're going to hear about, you're not actually going to perform in lab, but you do need to understand for the didactic exam. And I'll point those out to you. The first thing you want to do is consider just, where your patient is, how they're dressed, and their positioning. And so ideally, you want the patient undressed properly and gowned for the exam, and you want them to be sitting at the edge of the table, the exam table. Now, in a hospital setting, you can use the hospital bed to raise them up and position them into a good sitting position if it's appropriate to their diagnosis. You want your room ideally to be quiet so that you can perform an adequate percussion, and you're going to find out today that it's actually pretty hard to hear the difference in sound of percussion, and then also auscultation. Again, you are going to walk in, you're going to provide hand hygiene, you're going to clean your stethoscope, and make sure that the room is also warm, making sure that the diaphragm of your stethoscope is warm and that there's privacy with no interruptions. Of barrel chest, and this shows you how to recognize barrel chest as well. So you can see that as we approach a 1-to-1 ratio, the AP and the T diameters are about the same. This is when we're actually looking and saying, well, this patient appears to have a barrel chest versus a normal chest where you see from the xiphoid process moving back to the spinal cord, it's half the distance than your transverse here. Additionally, we're talking about respiration patterns. We see that we have 4 different types of words that we can use to describe somebody's respirations. Whenever you see the EU, that's normal. Eupnea, tachypnea is when it is too fast, just like if your heart is beating too fast, we use the term tachycardic. With breathing, we call it tachypnea. Bradypnea means your breathing is the rate is lower than normal. And then apnea, when we have periods of breathing in a normal pattern, and then we have pauses, and then breathing again, and then pauses. So it's a very irregular rate. We also can talk about respiration patterns in terms of depth. Is the person breathing very shallow? Are they breathing with increased depth? And then when we talk about rhythm, hyperventilation or hypoventilation, this is different than breathing too fast or too slow. We can have someone that's breathing at the regular rate, but every time they breathe, they're taking such a big increased depth and then releasing it, increased depth and releasing it, then you're getting hyperventilation because you're exchanging the CO2 and the oxygenation at a greater rate than you would if you were just moderately breathing. The same thing with hypoventilation as well. So we're still in inspection, and part of inspection is looking at that thoracic cage, and part of that is the spinal cord. So you will check and note if there's any scoliosis, if there's any kyphosis, and if there's any lordosis, which is a lower lumbar curve. Sometimes you see this in pregnant women where they stand and they have their hands behind their back. It's not just because their back hurts with increased pregnancy, but they're opening up that thoracic cage too, trying to breathe as well. We're moving on now to our next technique, which is palpation. And you're going to use your fingertips to gently palpate for lumps, masses, and tenderness. So you've already scanned initially the skin. You've looked for any obvious signs, and now you're using your fingertips to actually feel. You're also going to use your dorsal side of your hand, and you're checking for temperature. And you're going to make sure that the patient doesn't have any diaphoresis or any edema that you can feel on that chest wall. When you're palpating over the ribs and intercostal spaces, you don't want to put too much pressure, but you want to put enough pressure where you can actually feel the rib spaces. Avoid breast tissue, and you might have to ask your patient to lift up the breast tissue in some areas so you can palpate more effectively. You're going to repeat your palpation on the anterior chest if you started posteriorly, and then you'll repeat it posteriorly if you started anteriorly. So you make sure that this palpation is occurring front and back. There's 2 special tests that we use in addition, and these all fall under palpation because you're feeling. And the first one is symmetric expansion. You can choose to do this anteriorly as well, or just posteriorly. The second one is this tactile fremitus, which you're using the base of your hands and you're moving it down the patient's back, and you're trying to feel the vibration, which tells you the quality of their breathing. So let me show you in more detail in the next few slides. So if you go back to the anatomy slides in the beginning, you can see that mid-scapular, the most inferior edge of your scapula is about T8. So if you can find that and you just move down just a little bit, you can find T9 or 10, or you can count from C7, T1, and go down. Basically, you need this landmark to find the symmetric expansion. So the first few pictures here, or the first 2, you see they're doing symmetric expansion at the level of T9 and T10. They're going to pinch just a little bit and have the patient breathe, and you're watching for that expansion moving of your arms, or excuse me, your hands. You can also do this anteriorly, starting at the xiphoid process and then checking for that costal angle, which is, again, should be about 90, and then watching the symmetric expansion there. So for our lab, we're only requesting that you check symmetric expansion posteriorly. And you're going to stand behind that patient. Again, you're going to move those thumbs medially to pinch just a little bit of skin. About an inch of skin is okay. And then you're going to ask the patient to inhale deep. And as they take a deep breath, you're going to watch the movement of their thumbs on their back. So you're watching your thumbs on their back. And they should move symmetrically. And this is showing you their expansion, symmetric expansion of the lungs. Now think about if you were to see asymmetric expansion, maybe when they take a deep breath, only one side moves or one side doesn't move as much as the other, then you're wondering, what is impeding the expansion of that lung field. These are the points for tactile fremitus, and although we're not requiring you to demonstrate this for your lab midterm, I do want you to know what tactile fremitus is for your exam. So tactile fremitus, you're using these 5 points and you're going bilaterally down the back and around the scapular edge to the base of the lung fields. And fremitus is going to vary among people, but it's important that it's symmetric. The vibration is symmetric, more so than how you feel the vibration, because again, it's going to vary. It should correspond very similarly on each hand. And so just between the scapula, about 2, 3, and maybe even at the level of 4, it might feel a little stronger on the right side than you feel on the left side because of the way the bronchioles bifurcate in that area. You also want to avoid palpating over the scapula because the bone is just going to dampen that vibration. You're not going to have good sound transmission or good vibration. And the next slide here will tell you what to do at each point. So each of those 5 points, you're going to ask your patient, starting from the apex to the base, to say the term 99 or blue moon. And every time you say that, it creates this resonant sound that creates the strong vibration. You're using, again, the palmar base of the fingers or the ulnar edge. I tend to use the ulnar edge, but you can also use the palmar base. And you're going to make sure that you feel that symmetric vibration. A good way to try to test this out on yourself to see, like, what is she talking about? If you just put your hand on the back of your neck and say, you can tend to feel that vibration. So that is also an example of fremitus and what fremitus may feel like. You're probably wondering, well, okay, what does it mean if there's decreased fremitus? If there's decreased fremitus and you're starting to think that maybe there's some type of obstruction or cause of obstruction that's causing that transmission of sound not to be as palpable. You can't find that vibration. A pneumothorax might cause this, emphysema, and even excess fluid in the lung fields. Now we're looking here for the sequence of percussion and auscultation posteriorly. You're going to use the same technique, however, in the anterior chest when you auscultate using this Jacob ladder pattern where you're zigzagging back and forth and you're making sure that you're listening bilaterally. So whatever side you're listening to on the left, you're listening to on the right immediately, and then you go down, listen on the right, and then move to the left, and you keep moving forward. And the reason you're doing this is because you want to make sure that you can compare the lung sounds on each side, that you can compare the percussion sounds on each side. You always start with the apices, and then you're going to move down to the base. And this is a technique that takes time because, number one, it's really loud in lab, so it's hard to tell if you're you're percussing and you're hearing a dull sound or a resonant sound, and it's something you'll train your ear to do over time. What I like to do if I can't hear the dullness versus the resonance is that I will go back to a dull area that I know is going to sound dull, like over the scapula, over something bony. And then I go back to that area in between the intercostal spaces to see if I can now appreciate a more resonant sound. So each of these spaces are telling you, listen in the intercostal spaces when you're percussing over the intercostal spaces. Otherwise, you're just percussing over a rib, which is also going to sound dull. What you should hear, resonance is low pitch, clear, and hollow. And this tells you that you have healthy lung tissue. Now, you're probably thinking, well, this is almost impossible because of the ribs, they're in the way. And you're absolutely right. So sometimes this isn't a very accurate test to do, and depending on the habitus of your patient, it may be very difficult for you to do. However, I want you to understand how to do it and perform it in lab. So you're percussing on each of those sites. It's usually about 5 centimeter intervals, depends on your patient's anatomy. And again, you're avoiding the scapula and the ribs. These are the areas where you are going to note resonance, and you can see in between every intercostal space you should hear resonance, and just above T1 and T2 of the shoulders above the scapula you should also hear resonant sounds. Once you get lower until T8, T9, T10, well, I think that's more like T10, T11, you're going to start to hear dullness. And this is because you have visceral organs below causing that dullness to occur. So you can't really understand the lower bases as well as you can understand the apices here. Also remember though that the lower lung fields really do start at T3 and then move and branch out more laterally. The next exam is diaphragmatic excursion. And diaphragmatic excursion is something you want to understand. However, we don't have you perform in the lab midterm as well. And the idea behind diaphragmatic excursion is that it allows you to understand the difference between the lung fields as they fill up with inspiration versus when you exhale as they come up. There's a great video in your Jarvis resources on Evolve and the Elsevier resources that helps you to see and helps you to map this out. But basically you're having your patient inhale and then you are percussing to note the difference between dullness and resonance, and then exhale and noting that that depth or that measurement, and you're marking the spots on the back of their body. That space between, if we're counting here, this is inhalation versus exhalation, that space difference should be about 3 to 5 centimeters in adults, although it can be even up to 8 centimeters in a very well-conditioned person. So again, this is a percussion technique that we don't have you demonstrate in your lab midterm. However, you want to understand that these are one of the tools for your respiratory system and understand that it may be an exam question in didactic. Okay, now we've inspected, we've palpated, and we've percussed. We're moving on to auscultation now. So you want to make sure that you are using the diaphragm of your stethoscope, and you're going to compare always bilaterally, whether you're checking anteriorly or posteriorly. You are going to begin always at the apices and move down to the bases, and you're using that Jacob's ladder formation, front and back. Listen for a full cycle, full breath sound. You're checking quality, intensity, trying to listen to see if there's any difference in the sounds between the right and the left side. You're going to have your patient breathe through their mouth and just a little bit deeper, but not faster than usual. And so what I would say to you in real practice, I tend not to give them any instructions except when my stethoscope hits your skin, I just want you to take a breath. Because already they're breathing differently because they know they're being assessed for the respiratory system. Make sure that your stethoscope, the diaphragm, is firmly on the chest wall so that you can hear and evaluate the presence of normal breath sounds versus abnormal breath sounds. Now you have to keep in mind too that there's some reasons why you might not be able to hear good lung sounds, and this is usually true to extraneous noises, in the room. So environmental noises, maybe your tubing of your stethoscope is rubbing together, dampening the actual breath sounds. However, if the room is cold, the patient may be shivering. Maybe it's the patient's own chest hair that's rubbing against your stethoscope, and now you think you're hearing pleural effusion or something like that. So making sure that your stethoscope is on their skin, although you will see healthcare providers listening to breath sounds over their gowns and paper gowns and clothes. I would like to see that you're touching the skin with your stethoscope. The following slides are going to talk about what type of breath sounds you're actually going to hear in each area. And you can see that remembering that the apex is in the anterior part of your lung fields really reach over your clavicle, about 3 centimeters or so. This is where you're going to hear bronchial or tracheal sounds. Sometimes they're actually called tubular sounds as well. I use the term bronchial. And these bronchial sounds, when you're listening, inspiration is only half the length of expiration. So you're going to hear inspiration quickly and then more expiration there. Then hugging the bronchial area, you're hearing bronchiovesicular sound. You're hearing inspiration and expiration at the same duration. Then the majority of your lung fields are vesicular, where inspiration is 2.5 times longer than expiration most of the time. Now, going to posterior now, the majority of your breath sounds are vesicular, although just by the first, second, third, and part of the fourth spinal processes, if you're hugging that area right there, you're going to hear bronchiovesicular sounds where your inspiration and expirations are pretty close together. Now this depiction here, these illustrations don't show you where to put your stethoscope. It's not like every place you see a V here, you're putting your stethoscope there. No, it's not that at all. You're going with Jacob's ladder. You're starting at the apices and then you're moving down about 5 centimeters, and you keep that pattern until you've reached all the lung fields, and you're doing that posteriorly and anteriorly. I've included some breath sounds here that you can hear so that you can note the difference in the lung fields. And I will try to play that.
Welcome to this new video. In this video, you will learn complete breath sounds. Breath sounds can be divided into normal breath sounds and abnormal breath sounds. Normal breath sounds are vesicular breath sounds, while abnormal breath sounds can be diminished breath sounds, completely absent breath sounds, bronchial breathing, or you may be able to hear added or adventitious sounds which include wheezes, crackles or crepitations, pleural rub, or stridor.
Okay, so I'm going to stop right there because I want to encourage you to listen to these sounds. You can find a lot of different versions on the internet. Unfortunately, they're really hard to hear unless you put your earpods in and listen, or your headphones. But what he was talking about were sounds that weren't vesicular, bronchiovesicular, or bronchial, right? So if you hear these type of sounds over the areas that are showing in these blue diagrams, then those are normal breath sounds. If they're not normal, they're called adventitious sounds, and those can be rhonchi, a type of wheezing. You can hear stridor, which sounds very much like a seal trying to breathe. You can hear crackling, which may allude that there is some type of consolidation or fluid in the lungs. So any type of lung sounds that are not these lung sounds, vesicular, bronchiovesicular, and bronchial, are adventitious sounds. And here's a slide for that. There's also a link for abnormal breath sounds in the slide deck. Lastly, if you are listening and you hear adventitious sounds, or you hear areas where you're a little bit concerned because you don't hear the regular sounds, then you may want to move on and perform special tests. Now, special tests won't be required in your demonstration in lab, but it is a good idea to listen to these special tests if there is points of concern. So they have to do with your stethoscope, as opposed to tactile fremitus when you said 99, 99, 99, and you're feeling that vibration as your patient says that. Bronchophony is with your stethoscope, and you're listening to certain areas of concern, and you have the patient say 99. And while you're listening over the chest wall, if there's normal voice transmission and the lung tissue beneath that is normal, then what you're hearing should be very soft, it should be very muffled and indistinct. But if you can hear it very loudly and you can understand exactly it sounds like 99, 99, 99 through your stethoscope, then that is abnormal. So it should be muffled. Egophony is when you have them say E, 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 and as they're saying that, that sound again should be very muffled. If it's not muffled and it sounds like then that's abnormal. And then the last one is whispered pectroliloquy, and that is when you have your patient whisper 1, 2, 3, 1, 2, 3, 1, 2, 3, and it should sound very faint and muffled. It's abnormal if the 1, 2, 3 is very clear beneath your stethoscope. And so there are 3 videos here that you can watch. They're really short, like 30-second videos describing these 3 special tests. So again, not testable in lab, but testable for your didactic. And quickly, we're just going to summarize our learning today. We talked about inspecting that thoracic cage. We're looking for skin, respiration, condition. We're also going to check the patient's facial expression, their level of consciousness, making sure that their position is nice and comfortable. You're checking symmetry and size and shape of their thoracic cage. Then you're going to palpate. You're going to confirm the costal angle anteriorly. You're going to check symmetric expansion posteriorly. And you can practice tactile fremitus, although it's not tested in lab. You're also going to palpate any areas of lumps, masses, or tenderness. You're going to check for temperature using the dorsal side of your hand. Moving on to percussion. We're not going to ask you to percuss anteriorly, but we will ask you to percuss posteriorly, starting at the apices to the bases using that Jacob's ladder zigzag technique over the lung fields, percussing in the intercostal spaces only. And you can also estimate diaphragmatic excursion if you choose to, but not testable in lab. Auscultation. You're going to assess breath sounds both anteriorly and posteriorly. You're going to start with the apices here, where you're going to hear bronchial sounds. You're moving down the chest wall, hearing bronchiovesicular, and then as you move out towards the outer lung fields, you're hearing vesicular sounds. Then you will do the same thing in the back, where you are checking for bronchiovesicular and vesicular sounds only. If you hear anything abnormal, you can perform the special tests: bronchophony, egophony, and whispered pectroliloquy. One more thing to note is that on your lab checkoff in your head to toe is that you're going to be asked to check for CVA tenderness. And you can see this in the Jarvis video, where you're checking at the level of about T8 to T9, and some people might even be T10. But you're checking right there using percussion. You're going to do direct fist percussion over that area to elicit or ask if that motion is eliciting any pain. And this is called CVA tenderness, costal vertebral angle tenderness. Sometimes you see it charted as CVAT if it's positive. And what you're trying to note is if there is tenderness, then it could allude to a kidney infection or kidney inflammation. And you're probably wondering, well, why do we do this at the lungs and thorax? Because we think about it in terms of just the respiratory exam. But really, when you're assessing that lung and thoracic area, you want to make sure that you're comprehensive and assessing everything that you can in that posterior thoracic area. Again, follow that up with your Jarvis video, and you can learn more about kidney disease in the GU section of the Jarvis textbook as well. So let me show you some sample charting. So this again here, the summary checklist is part of what you'll be learning in lab and practicing, but the sample charting here will show you a negative or a normal chart and what that respiratory chart would look like. And so here subjectively, you're talking to your patient, you've asked these questions. So ask your partner these questions so you can elicit these answers. So you're asking your patient about the review of systems. You know, do they have a cough, shortness of breath, chest pain, or breathing? Here, this patient does not have a history of respiratory disease. This patient has 1 to no colds per year, doesn't smoke, works in a well-ventilated space with no secondhand smoke exposure, had their last TB test 4 years ago. So for you guys, it'll not be 4 years ago. It should be within this last year. Should be negative with no chest x-ray to confirm. Now, if you have more to add to this because you've had a little bit more detail in your subjective interview, you may add to this, but this should be the baseline of what your subjective charting should entail. The next part is objective history, or excuse me, objective findings, which is your actual hands-on assessment. So part of your inspection should include these things, and I want you also, don't forget to talk about skin. It doesn't talk about skin here too much, but you want to note the skin color is appropriate to race and ethnicity. I don't see any lumps, or excuse me, I don't visualize any lumps or lesions or masses. I'm looking at the symmetry and the size and shape of the patient's thoracic cage. The AP diameter is less than the transverse diameter. You can also put the ratio if you want, 1 to 2. Respirations are, in this case, 18 beats per minute, relaxed and even, not using any accessory muscles to breathe. Chest expansion is symmetric. You talk about the costal angle is about 90 degrees. If you do tactile fremitus, you can say it's equal bilaterally and with a little bit of decrease at the base. There's no tenderness to palpation, no lumps or lesions when you're palpating. Now with resonance, you hear resonance, with percussion over the lung fields, and you can note that this was posterior. If you choose to try diaphragmatic excursion, you can also chart that there, but it's not required. If you want to see, again, diaphragmatic excursion in more detail, check the Jarvis video. They have a good example. And then you're going to talk about their normal breath sounds. So here in the charting, it only talks about vesicular breath sounds here over lung fields. But remember, we also are assessing bronchial and bronchiovesicular. So I want to see that added in your charting. So it should be, bronchial, bronchiovesicular, and vesicular breath sounds are clear over lung fields in the appropriate areas. So you don't have to necessarily tell me exactly where you're hearing the bronchial, bronchiovesicular, and vesicular when you're charting, as long as they're normal in all the appropriate areas. But if there's an area where you might hear an adventitious sound, you want to call out that area specifically and what that sound was. In lab, however, when you're listening and when you're getting checked off for your midterm, you want to make sure that you're, as you're listening, you're thinking about, whether you're hearing bronchial, bronchiovesicular, or vesicular sounds, and then you want to call that out in your verbal charting. That will be the end of our lungs and thorax lecture. The rest of the slides showing abnormals will be for you to just further your understanding of some abnormalities in the respiratory system, but we won't be talking about that in lecture today. Please practice your hands-on this afternoon and let me know if you have any questions.